Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
I'd like to welcome today Dr. Jack Dale from Toronto, Ontario. Jack is a member of the Tweed Foundation, is an immediate past president of the American Board of Orthodontics. I'd like to thank you very much for coming to Ann Arbor today.
Jim, I'd like to thank you for allowing me to participate in this interview. It's an honor when I take a look in your office of all those people you've interviewed in the past. I consider it quite an honor.
Our topic today is serial extraction and the treatment of the mixed dentition patient. I know that over the years you've had probably as much experience as anyone in this type of treatment, and I'd like to discuss a bit on how you got into the practice of serial extraction, perhaps defining what it means to you, and then saying how it is now as opposed to how it was when you first started.
Well, I credit Dr. Maurice with motivating me to carry out serial extraction. Dr. Maurice, as you know, is one of the world authorities in dental development. And I felt that I should take advantage of his expertise. And you'll notice that many of the references in my lecture go back to the 60s when Dr. Maurice was very active in dental development research. And so with all his studies in dental development, I want to take advantage of that knowledge and put it to work in the clinic. Most of his articles were in journals that dentists don't read, anatomy journals and so on. And so I just felt it would be a waste if someone didn't take his wonderful material and put it to work with patients. And so I really credit him with getting me started in serial extraction and based on his biological principles. And Dr. Duell certainly influenced me as I read his articles, and Dr. Woodside also, when I was an undergraduate student, was promoting serial extraction throughout the country. And so I guess those three people really got me started in it.
How do you define the term serial extraction?
Well, I don't like the term serial extraction. I prefer guidance of occlusion or guidance of eruption, as Hotz defines it, rather than Kellgren, who really is the man who defined the term serial extraction or coined the phrase serial extraction. And to me that has unfavorable implications in that it's just a series of extractions, whereas guidance of eruption or guidance of occlusion infers that there's some basic knowledge required of dental development, anatomy, cephalometrics, and so on for you to carry this out. And so I prefer the term interceptive guidance or guidance of occlusion or guidance of eruption rather than serial extraction.
Now, does serial extraction in your hands always mean the removal of permanent teeth?
No, definitely not. I'm constantly monitoring as we go along. And if I have to put in a little holding device, if I start out, let's say, with the patient not having an alveolar dental protrusion, the teeth are quite upright, I will put in a lingual arch or something just to hold those teeth in that proper position. Or I'll put on a headgear, I'll put in a little removable appliance to correct a crossbite or something. So I'm constantly monitoring my process. I'm constantly adding some appliance therapy, just simple appliance therapy, to go along with that guidance. Serial extraction it helps to cut down on the multi-banded treatment. I cannot think of too many patients that I have done serial extraction and I haven't followed up with a multi-banded appliance. I once asked Dr. Ramshard, who's from Michigan, I believe, do orthodontists really contribute to the periodontal health of a patient? If we give them a beautiful occlusion, does that mean that they're going to keep their teeth longer? And through the discussion, he said some of the worst periodontal conditions that he has witnessed are patients who had serial extraction and were not followed up by the multi-banded therapy to give them a good coordinated alignment of the dentition.
Now, what would be the usual routine? I mean, when would be the time you'd like to see a patient for evaluation, and what types of records would you take, and what what protocols would you follow? Let's say in a Class 1 case that was either severely crowded or a borderline crowded case.
Well, I never start any patient without taking full records. I don't take out one primary cuspid until I've taken full records. What's the major decision we have to make as clinicians? Do we extract teeth or do we not? And to add the dimension of time and to complicate it with growth and development and do it in a serial fashion makes it even more difficult. There's a great misconception out there that serial extraction is an easy procedure. It is definitely not. It's difficult. And so I take full diagnostic records before I start. And then I put Dr. Maurice's concepts to work. In other words, a tooth is literally standing still until half of its root is formed. So I never take out a primary first molar until I see that that permanent premolar has half of its root formed. If I take it out too early, then there's a knife edge ridge formed and it slows down the process rather than speeds it up. He also has data that shows it takes a certain time to go from root 1/4 to root 1/2 to root 3/4 when the tooth, according to his data, erupts into the oral cavity. So I use these data to help me decide when to remove the primary cuspids, the primary first molars, the permanent premolars, and so on.
So then when you, let's say you had a patient who had a reasonable face and had crowded lower incisors, and you were anticipating that this patient would be an extraction case because of gross crowding, what would be the sequence that you would use routinely, or is there a sequence that you can define?
Well, there are several serial extraction sequences depending on the type of orthodontic problem we have, and I've outlined those in Graeber's textbook. Sometimes when they have alveolar dental protrusion, for instance, that's their major problem. The alignment is not bad, so we may take out the primary first molars first to get the bicuspids in, because we don't have to really line up the mandibular incisors, and we proceed with the first molars first rather than the cuspids. Sometimes we have splayed lateral incisors. They're not even touching the primary cuspids, and the crowding is really at the apex of the root of the lateral. The cuspids are up against the lateral, so we take out the primary first molar first. The premolar drops down into that spot. The cuspid comes off the root of the lateral incisor, so we're relieving the crowding up in the root area rather than down in the incisor area. And sometimes I'll do that even in non-extraction patients, just to get that relief up there. And in 30 years of practice, I've never seen a lateral incisor that had their roots resorbed, because I feel like I'm relieving that area early. But if they have crowded lower incisors and we're under pressure from the parents to do something about that one incisor that's blocked the way out, then we usually proceed with the primary cuspids first. And then usually I do the lower incisor, mandibular incisor, maybe 9-10 months prior to the maxillary incisors.
What do you think are the
cuspids, I should say.
What do you think are the biggest advantages of serial extraction?
Well, there are many advantages. Why allow a major malocclusion to develop when you can intercept it and literally cut down the treatment by 1 year at the sensitive teenage period? So mainly it's to intercept something rather than to allow it to happen and then react to it. So I like to be a step ahead of it so that those patients don't have to experience tremendous malalignment of the dentition. So, and it's also less expensive, much less expensive, when you can carry them through interceptive guidance and you start maybe at 7.5 or 8 and go through to about 11.5, and you only see them every 4 or 5 months, and the fee is very small relative to the multi-banded fee. So if you can cut a year of multi-banded fee out at the sensitive teenage period, that's a wonderful objective for serial extraction. And there's a certain segment in my practice that benefit from that. It's not all my patients by any means. It's a fraction of my extraction patients.
What are any disadvantages of serial extraction, or things that you've seen go wrong in a certain segment of the population?
There's many disadvantages. That's why I say it's not an easy procedure. To me, the key for all of orthodontics is diagnosis. And I think one of the key diagnostic criteria that we use is that patient a high-angle face or a low-angle face? With high-angle faces, we routinely extract teeth. With low-angle faces, we routinely treat non-extraction. So that's one of the first things you have to decide. Are we dealing with a low-angle face that might not have extraction, or are we dealing with a higher angle? Now, The extremes is not good either in the high angle face, because we may take out molars or something. That's not the result of serial extraction. Or we may take out upper first premolars and lower second premolars. Again, that's not the result of serial extraction. So deciding on what patient to do it in is very important, and the diagnosis is the key.
Now, you talked about high angle, low angle cases. What other criteria would you use in identifying which patients would be a candidate for early intervention?
Well, I have what we call total space analysis that I try to determine a tooth size, jaw size discrepancy. And that is a wonderful diagnostic method, because it differentiates between anterior crowding, mid-arch crowding, and posterior crowding. And that will also in turn dictate whether I take out 4 first premolars or upper firsts and lower seconds, or all seconds, or even molars. And so total space analysis is very important, along with the proportional facial analysis. It's kind of a classification of faces into class 1, 2, and 3 faces, and then it differentiate. For instance, a class 1 face, a class 1 dentition could have many different treatment plans according to their facial pattern. For instance, we can have a class 1 dentition, and we can have a maxillary mandibular alveolar dental protrusion, which would probably have 4 first premolars extracted. Or we could have a maxillary mandibular alveolar dental retrusion, which would probably be treated non-extraction. Or we could have a prognathic maxilla and mandible, which may not need extraction because of the larger jaw size. Or we could have a retrognathic maxilla and mandible, which may require the extraction of 4 second premolars, so that we bring the mandibular molars forward. So just because it's a class 1 dentition, we must consider the face. So many people in general practice do serial extraction, but they totally ignore the facial pattern, and I think that's key. And as I mentioned this morning, one of my important diagnostic records is the facial photographs, and coordinating that with cephalometrics.
Do you see, when you extract, let's say, deciduous canines, that upon occasion the lower incisors will not only align, but they'll also tip lingually? And do you find that sometimes by removing the lower canines, deciduous canines, that you actually begin to commit yourself more toward an extraction protocol?
Well, I monitor the axial inclination of those lower incisors very carefully. And in an alveolar dental protrusion, it can cut back a treatment 6 months. If the tooth is already upright, we may be dealing with a low-angle facial pattern, and we may not even want to do serial extraction. But let's say there's severe crowding and we're faced with that. I will put in a holding arch to keep that lower incisor in a good position.
Have you ever been in a situation where you've gone into a protocol of serial extraction and then regretted that you did that?
Oh, sure. I've made every mistake in the book.
What are the mistakes that you would, you know, after 30 years of practice, the things that you now, if you knew then what you know now, that type of thing?
Well, again, I would pay very close attention to this low-angle, high-angle facial pattern, because those are the ones you dish in the face if you take out teeth. And there's no one who abhors a dished-in face more than I do, and more than many Tweed practitioners that I know. So that we don't want to create dished-in facial patterns, and so we try very hard to treat patients non-extraction if they tend to be that low-angle facial pattern.
Now, I want you to, let's expand our topic just a little bit and put serial extraction within the whole context of early treatment, because I know that within your practice you do treat a fair number of people that are in the mixed dentition. That's true, right?
That's true.
What percentage of patients, let's say if you took 100 7-year-olds or 8-year-olds in your practice, what percentage of patients would undergo a serial extraction protocol versus other types of interceptive treatment?
All right, let me say that as I look at my practice, the amount of extraction I do from one year to the other varies, because, for instance, there's a large influx of Oriental people into Toronto right now, so it's changing my whole figure system. So I would say that I probably extract teeth 50-50, 50% extraction, 50% non-extraction. It may vary one way or the other. Of the extraction patients, I'd probably extract serial extraction in about a third of those patients. So about a sixth of my practice would be serial extraction patients. And those are ones with good facial patterns, severe dental crowding, or tending to an alveolar dental protrusion and a high angle.
Now, are we, again, I want to make sure we're defining what we're talking about. In that context, are you talking about, let's say that serial extraction leads to the removal of 4 teeth, 4 permanent teeth. Is that what you're talking about, as opposed to the guidance of eruption, which may or may not lead to?
No, I'm talking about serial extraction.
Okay, so we're going to define it for this purpose.
I do, as far as mixed dentition, I do more than a third of half my practice.
Okay.
I do, gosh, it's half my practice is early treatment. Maybe more.
Let me ask you a little bit different way of looking at it. If you took 100 adolescent patients and you were to extract or not extract versus somebody that you could see at 7 or 8 years of age, and let's say that in general you extract half the time, would you extract half the time in adolescent patients and half the time ultimately in mixed dentition patients? I
think I would extract more in the adolescent patients because I don't have the benefit of growth. For instance, in a class 2 patient, I might give them headgear to move the maxillary molars back into a good position, and we may be able to do that without extracting teeth. Whereas when they get into the permanent dentition, I may take out upper first and lower second premolars or something like that. Yeah, I think my own experience, I've been doing a fair amount of early treatment over the years myself, and I think one of the things that I have come to appreciate more than ever is the leeway space, the E-space, whatever you want to call it, as being tremendously important in regard to, as opposed to just letting somebody go, you know, and just letting them wait till they got to the adolescent dentition. That many times those borderline cases, even with a lingual arch in the lower, seems to work out quite nicely. Oh, I agree totally. I agree totally. And I've even had adolescents who come in with tremendous crowding in the lower arch, very excessive deep overbite, and class 2 malocclusion, class 2 division 2. And I would still bend over backwards to treat that patient non-extraction by torquing my maxillary incisors up and out of the road and then uprighting my teeth. And it's amazing the amount of space you get to align that into a good class 1 relationship. Are there any other comments that you would like to make regarding serial extraction, or for someone who is just becoming familiar with that technique, some things to watch for? Or? Well, I would just like to support the procedure. We're now in an era of non-extraction treatment. I'd like to say that I really haven't changed my philosophy with regard to extraction versus non-extraction over 30 years. I tried very hard at the beginning of my career to establish a good diagnostic protocol and a good treatment regimen. And I have found that very effective in producing good results. And those results have stood up over 20 years. And so for me to dispense with all of that and treat all my patients non-extraction would be admitting that I'm doing it wrong for 30 years. That would be very difficult for me to do. And so I continue to practice much the same way as I have for the past 30 years as I've developed and improved. I think the introduction of brackets, as we were discussing, has cut down on my extraction maybe 10% because of the interproximal area. And that pleases me to no end. I really I think that's good. And also it's much more relaxing practicing with the brackets. And so I still continue to do my serial extraction because it's a tremendous benefit for a certain portion of my practice. There's no question about it. Anything else? Not that comes right off the top of my head. Okay. Well, thank you very much. I appreciate you taking your time. Thank you, Jim. It's been a pleasure. Okay.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.